This is our discussion on the metabolic bone disorders. So when I talk about the metabolic bone disorders, this would include your osteoporosis, your Paget's disease, your bone tumors, your lesions, and a variety of deformities and syndromes. Now, your older adults are at increased risk of these metabolic bone disorders. Also, statistics would have it that the incidence of bone cancer is increasing in both the young and old population. And primary bone cancer is already found oftentimes in adolescents and young adults. Hence, our knowledge on metabolic bone disorders would be important. Okay, so first is osteoporosis. When I talk about osteoporosis, take note this is a chronic metabolic disease. A chronic metabolic disease in which the bone would lose its density and possibly would lead to fracture. In fact, it is referred to as a silent disease, silent in the sense that the first sign that people would often see on a patient with osteoporosis is already the fracture. If you would look at the pathophysiology of the disease, fracture is already a late part of this disorder. Whereas people would just discover that they would have osteoporosis because of the experience of fracture. Now, the hip, spine, and wrist are most often at risk, although the bones would have fracture. Okay, any bone could have the fracture. So, it's considered to be the most prevalent of the bone disease in the world. We have the term osteopenia. Your osteopenia is referred to as a precursor to your osteoporosis. So, meaning it's a condition that precedes your osteoporosis. When I talk about osteopenia, penia there would incline or would mean the low bone mineral density. The worst or the common sequelae also of your osteoporosis is bone fracture. So again, the common sites affected could be your hip, your spine, and then your wrist. So that's why oftentimes your patients with osteoporosis are candidate for femoral they would have femoral fracture, candidates for hip replacement. It's more often common among women, wherein 1/2 of them would have osteoporosis, and then you also have 1/5 of them among men. Then you have your so more on osteoporosis. Let's take note that the bone mineral density would peak between 25 to 30 years old. So what do we mean by that? After 25 to 30 years old, we expect the bone mineral density already to be decreasing. So before and during the peak years, osteoclastic and osteoblastic activity are equal. Okay, so both of these activities are equal. However, after the age of 30 or 25 to 30, after the peak years of your bone, after the peak years, the bone resorption would exceed the bone building activity. In other words, the osteoclastic activity is becoming increased in contrast to your osteoblastic activity. With that, it leads to decreased bone density. Okay? So, the main problem on the pathophysiology of osteoporosis is that the osteoclastic activity is greater than the osteoblastic activity, resulting to the decrease of your bone mineral density. So, what are the different classifications of your osteoporosis? So, it could either be generalized, it could either be, or regional. So, when I say generalized, a lot of structures are affected. When I say regional, as the term implies regional, this is usually secondary and occurs when a limb is immobilized. So it's related to immobilization. So meaning it could be that the arm is only part affected, it could be only the leg affected. Whereas in your generalized osteoporosis, it's throughout the body. Okay? A lot of bones will be affected. So under your generalized osteoporosis, it could be considered to be primary or secondary. When I talk about primary, being the more common, it's caused usually by postmenopausal episodes, and in men, usually found in the 7th or 8th decade of life. Whereas in your secondary osteoporosis, this would result from medical conditions, which would include your hyperthyroidism, long-term drug therapy, and even your prolonged immobility. So, take note of that. Here are the different risk factors for your primary osteoporosis. 1. Age 65 years old and older. The age 65 years old and older in both in women, if it's 65, in men it's 75 years and older. So what happens when the aging process would occur? There will be a decrease of your estrogen, and there will be also a decrease of your testosterone. These sex hormones are known to have protective effect on your bones. Okay, the protective effect is in fact due to their proliferation of the growth of your osteoblast. In other words, your estrogen and your androgen or your testosterone would increase the formation of your osteoblast. In other words, again, they would lead to bone formation. Whereas after menopause and after andropause, there would be a decrease of your estrogen and testosterone. So this decrease in the androgen and testosterone is the one of the primary reason why there is osteoporosis. Next, family history of osteoporosis. So it tends to be genetic. Then, history of low trauma fracture after the age of 50. The low trauma fracture lead to a poor bone healing later on. Caucasian or Asian ethnicity is one. Then you have low body weight and thin build. So, what's the contribution of low body weight and thin build? Recall that if our bone is not weight-bearing, the tendency is for the bones to decrease in size. Okay, the tendency is for the bone to demineralize. So if you are dealing with people who are very thin, the tendency is that their bone are also more fragile and porous compared to those people with medium to big build. Because people who would have medium to big build would have exercised their bone because of their weight. Okay, their bones are weight-bearing. Okay, which would mean that there is a increase in bone mass. Next, chronic low calcium intake, meaning for a long period of time, you're not taking anything which contains calcium. Okay, for example, that could be your cancer, okay, that could be your NPO, or that could be your lactose intolerance. Next, estrogen or androgen deficiency. So the same reason for the andropause and menopause that I have mentioned. Women with other risk factors, let's say for example, using pills. And then the history of smoking. So your smoking would decrease the vascularization going towards your bone. It also impairs the absorption of calcium. High alcohol intake could also impair the absorption of calcium. And then the lack of physical exercise or prolonged immobility. The lack of exercise and prolonged immobility would lead to demineralization of the bone also due to the increase of your osteoclastic activity, hence leading towards your primary osteoporosis. Then for your secondary osteoporosis, so when I say secondary, there is an underlying general medical condition. So diabetes would be one related to the increase of your sugar. The increase of your T3 and T4, so the increase of the thyroid hormones would lead to overactivity. And because of that, there is a tendency for overusage of the bone, and there is also hyperactivity of the bone. Next, you have your increased PTH. So recall that one of the function of your PTH is to pull out calcium from the bone, leading to demineralization also of your bone. Next, you have your Cushing syndrome. So your Cushing syndrome would work on the same way that your patients who are taking steroids would be at risk for osteoporosis. So take note that the increase of the steroid levels in the body would promote bone demineralization. Okay, so Cushing syndrome. Your Cushing syndrome is also an increase of the steroids in your body due to the hyperactivity of your adrenal cortex. Okay, so take note there will be an increase of the 3S, your salt, sex, and sugar. So one of the effect is osteoporosis. Other than that, decrease in growth hormone. So the decrease in growth hormone would lead to the decrease on the stimulation of the growth and thickening of your bone. Next, metabolic acidosis. Your metabolic acidosis could result to demineralization of the bone. Other than that, you have your female hypogonadism. So once there is hypogonadism, the gonad is ovary. Okay, so your ovary, which also produces your estrogen would be decreased. Then you have your Paget's disease. So your Paget's disease is also characterized by an increase of osteoclastic activity. Okay, one of the difference of your Paget's disease to your osteoporosis is that even if there is an increase of osteoclastic activity in Paget's disease, there is a compensatory increase of your osteoblastic activity. We'll talk about that later on. Then you have your rheumatoid arthritis, okay, another autoimmune disorder. Then you have prolonged immobilization. As mentioned, when I say prolonged immobilization, may that be related to fracture, may that be related to stroke, okay, may that be related to neurodeficit that would lead to demineralization of the bone and decrease of the bone mass. Okay? Bone cancer. Your bone cancer, among the most painful, it would be able to destroy your bone mass. Then you also have your liver cirrhosis. So with your liver cirrhosis, you will have problems with vitamin D metabolism. Recall that vitamin D is considered to be a fat-soluble vitamin, which is primarily processed through your liver. Okay, with the problem on the vitamin D, the problem with your calcium would follow. Then you have your HIV/AIDS. Okay, this immunocompromised state would lead to bone porosity. It would increase the porosity of your bone. And then chronic airway limitation. So the chronic airway limitation may lead to your chronic airway limitation could be characterized by asthma. Asthma would be the use of steroids, and then steroids could destroy your bone. Other than that, your chronic airway limitation could also lead to acidosis, okay, which would, as I mentioned, could damage your bone. And then the chronic airway limitation with the decreased oxygenation going towards your bone would also damage the bone, okay, leading to making your bone brittle. Then you have your corticosteroids. As mentioned, as mentioned, you have your corticosteroids or your steroids could damage your bone. Then you have your heparin. Then anticonvulsants, phenobarbital and phenytoin, ethanol. So these are drugs that could all decrease your bone mass. Okay, chronic use of these drugs would lead to decrease of bone mass. Then we have drugs that induce hypogonadism. So hypogonadism, that will be again leading to the decrease of your estrogen and testosterone. High levels of thyroid hormone, especially if we're talking about your patients who have hyperthyroidism or your patients with hypothyroidism and managed with thyroid replacement therapy. Then your cytotoxic drugs. Okay, so your cytotoxic drugs, drugs that are used for cancer management. Then your immunosuppressants and also your loop diuretics. For the loop diuretics class, it will be related to the excretion of calcium. Okay, related to the excretion of calcium. Now, what are the assessment findings? You'd have back pain. So when we're performing, by the way, a musculoskeletal assessment, of course, you would need to inspect and palpate the vertebral column. Why? Classic to your osteoporosis is the appearance that we refer to as your dowager's hump. So when I say dowager's hump, okay, kyphosis that results to decrease in height. Okay, so there is an abnormal curvature on the upper back of your patient, which leads to decrease in height. This abnormal curvature is actually caused by the fractures that is caused by your osteoporosis. Okay, so normally or usually patients who have had the dowager's hump would say that they claim that they have gotten shorter by 2 to 3 inches within the previous 20 years. Other than that, your patient would manifest tenderness and voluntary restriction of the spinal movement. This voluntary restriction of your spinal movement would suggest that one or more compression vertebral fractures are present. So when I say compression vertebral fractures, the fracture is already compressing on the nerves. Okay, for that reason, your patient would be limiting movement. Then you have your constipation, abdominal distension, reflux esophagitis, and respiratory compromise in severe cases. Okay, so constipation, abdominal distension, these are all related to fractures. So once there is a fracture on the vertebrae, the tendency is that the innervation of the nerves going towards this area will be affected. Your respiratory compromise is usually associated with a structural change or structural damage brought about by the fracture. Okay, then you have your fractures. So there's a lot of fractures going on in osteoporosis. Now we will have a specific topic on fractures. So what are the laboratory findings for a patient with osteoporosis? Serum calcium, vitamin D, and phosphorus. Now for the serum calcium, that would depend on the cause of the osteoporosis of your patient. If the osteoporosis is caused by the rapid bone breakdown, in which case we are saying that the osteoclastic activity is greater than the osteoblastic activity, we would find out that the serum calcium is elevated. In the same way in immobility, if your patient have been immobile for long, the tendency is that the serum calcium will also be even elevated. Vitamin D. Your vitamin D levels may be decreased. Okay, because your problem in this patient is that they are unable to absorb calcium due to the decrease of vitamin D. By the way, on the other hand, if your patient's osteoporosis is related to the chronic decrease of intake of calcium-containing substances, you would expect the serum calcium levels to be decreased. Next, you have your phosphorus. Your phosphorus is usually inversely related to your calcium. So if there's an increase in the levels of calcium, the phosphorus levels are expected to decrease. Next, you have your urinary calcium levels. Okay, again, in osteoporosis, usually the osteoclastic activity would be more than the osteoblastic activity. So what happens is that there is a lot of calcium going on in the bloodstream. Because of that, there will also be a lot of calcium going on or being excreted through your kidneys. Okay, so urinary calcium levels would also be increased. Serum protein measurements. So protein measurement may be increased, especially if there is liver damage. Thyroid function. So the thyroid function would be increased, especially in hyperthyroidism. Then urinary hydroxyproline levels. Your urinary hydroxyproline levels are elevated in Paget's disease. Okay, it's particularly specific to Paget's disease. However, your urinary hydroxyproline level would also indicate an increase of the osteoclastic activity and bone resorption. Okay, so it may be increased also in osteoporosis because it indicates an increase in osteoclastic activity. Now you have the list of biomarkers there. One is your bone GLA protein. So your bone GLA protein is actually dependent on your vitamin K. Your bone GLA protein is actually synthesized by your osteoblast. Okay, so this would indicate, or this would be an indicator of your bone turnover. Once there is an increase in serum bone GLA protein, that would mean that the osteoblastic activity is increased. Then you have your BSAP. Your BSAP is your bone-specific alkaline phosphatase. It's bone-specific, but when it comes to disorders, this is non-specific, and it could be mildly elevated in patients with fractures. What do I mean by non-specific? So when I mean that the diagnostic test is non-specific, it means that once the diagnostic test is positive, it could mean a lot of disorders. Okay, so this one is non-specific. It's mildly elevated even in fractures. It could be elevated also in hyperthyroidism, Paget's disease, osteomalacia. Then you have your NTX. So NTX is your N teleopeptide, and then you have your C teleopeptide. So these are carboxy-terminal collagen cross-links. But take note of their use, that they are biomarkers to measure the rate also of your bone turnover. Okay, basically the purpose is to measure the rate of bone turnover. Then you have your pyridinium. Your pyridinium is also talking about your collagen. This is also used for screening of osteoporosis. There's a study that would say that this is good for detecting for overt vertebral osteoporosis. So these biomarkers are basically not specific to your osteoporosis, but they are used to rule out other disorders which would manifest as like. So what are the assessment or imaging assessment used for osteoporosis? You have the X-ray of the spine and long bones, in which we would detect that there is a decrease in the bone mineral density. Second, the most common diagnostic test used is your dual X-ray absorptiometry. Now, your dual X-ray absorptiometry is considered to be most common. It's considered to be a screening and diagnostic tool for measuring bone mineral density. Okay, so oftentimes you would see this in grocery marts. Okay, you would see that there are people who are a nutritionist dietitian and would advise you to have your bone mineral density measured. Then you have your QUS, your qualitative ultrasound. So the QUS of the heel is also considered to be effective. It's a low-cost screening tool that is used to detect osteoporosis and even predict your risk for hip fracture. Okay, so again, heel. Okay, what's being done is ultrasound of the heel. Then you have T-score. So the T-score is actually the standard of diagnosis for osteoporosis. Your T-score, if you can recall your lessons in statistics and mathematics, your T-score would be the one to represent the number of standard deviations wherein the patient is above or below the BMD. So recall that you have the curve that you've discussed in statistics. Okay, the one that is shaped like a bell that we refer to as a normal distribution. So if this is the average bone mineral density of young adults here at the center, okay, let's say for example, that's the average bone mineral density for Filipinos. When I talk about osteoporosis, it can be diagnosed if you are 2.5 standard deviation, okay, away from your or below from your average. So what do I mean by that? If your T-score is 1, you would belong here. If your T-score is 2, you would belong here. 2.5 would belong here. And you are considered to have low bone mass if you belong between first standard deviation and 2.5 standard deviation. However, once you are on 2.5 standard deviation and lower, that would be already the diagnosis of your osteoporosis. So this classification would come from your World Health Organization. You may pause the presentation to copy. Now, just for you to have a grasp of what is the pathophysiology of osteoporosis. So there are primary causes and secondary causes. So the risk factors that we have mentioned. Other than that, it is related to the decrease of your calcitonin. Remember, calcitonin is the one that decreases your blood calcium levels. So in the process of decreasing the blood calcium levels, your calcitonin would send the calcium back to your bone. So if there is a decrease in the action of your calcitonin, it would just continue to lead to bone breakdown. Okay, the continuous increase in your PTH would also lead to bone breakdown. Remember, your PTH would increase your blood calcium levels. And in the process of increasing the blood calcium levels, your PTH would be getting calcium from the bone. Then the decrease of your estrogen. So recall that your estrogen is considered to have your bone protective effects. So because of this, okay, especially the aging process combined with that, bone resorption would be greater than bone formation. Okay, in other words, the osteoclastic activity will be greater than the osteoblastic activity, which would result to the decrease of your bone mass, the decrease of your bone matrix, and then the decrease in your bone architectural strength. That being said, that makes your bone to be porous, brittle, and fragile. Once the porous, brittle, fragile bone would have fractures and it would damage your T10 to L2, one possible problem is your paralytic ileus. Okay, so your thoracic 10 to lumbar 2, that would lead to paralytic ileus. So recall paralytic ileus as the term implies paralysis of your small intestine. Okay, absence of bowel sounds. Other than that, okay, in chronic osteoporosis, if there is already gradual collapse of the vertebra, that would lead to kyphosis. So you have the classic appearance dowager's hump, the loss of height, okay, typically 2 inches in the last 20 years. And then relaxation of your abdominal muscles. Okay, you might think that there's a baby bump there, but the abdominal muscles are relaxed because of the decrease in the curvature or the forward curvature, of your spine. Then, another risk for the gradual collapse of vertebra would lead towards your pulmonary insufficiency. Okay, that's why it needs to be addressed. Okay, so here are the complications. You'll have fracture, either the thoracic and the lumbar spine. You'll have your hip fracture. Then there could be your Cole's fracture. Okay, your Cole's fracture, we'll discuss that under fractures. Then we have the diagnostic test. So X-ray. So your thoracic vertebrae would appear to be wedge-like. Your lumbar vertebrae would appear to be biconcave. And then for the screening examinations, we are recommending the use of your DEXA, okay, your absorptiometry for bone mineral density assessment. Included for all women greater than 65, included for all people who are greater than 50 with risk, and all who had fracture due to osteoporosis. Next, if your patient would have the gradual problem on the vertebrae, one thing that could be done is the reduction. Okay, or when I say reduction, that's the repair of your fracture. We could also do your joint replacement, and we could also have your PMMA. Class, your PMMA is polymethyl methacrylate. Again, sorry, polymethyl meta or methacrylate, PMMA, which is used for your percutaneous vertebroplasty or kypheloplasty. Okay, so that is listed under surgery. Your percutaneous vertebroplasty or kypheloplasty or kyphoplasty, So your PMMA is a bone cement injected into the fractured vertebra, which is usually followed by an inflation of a pressurized balloon to restore the shape of the affected vertebra. Okay, so you have here listed the risk factors related to your osteoporosis. So alcohol, tobacco, family history, bone fracture during adulthood, inactive sedentary lifestyle, inadequate calcium vitamin D intake, low BMI. Okay, particular emphasis here on malabsorption disorder, an example of which is your eating disorder, your celiac disease, which leads to irritation of the bowel, hence poor absorption of calcium. Then you have your bariatric surgery. In bariatric surgery class, there will be a resection of a stomach wherein only a small part of your stomach is left to your patient. Okay, so leads to poor absorption of calcium. Then andropause, then you have menopause, and then steroids that would last for longer than 3 months. Okay, like your prednisone. This image is actually retrieved from that of your Brunner and Sudar. Okay, so if you look at this 10 years post-menopause, it will appear like that. Okay, 15 years post-menopause, and then 25 years post-menopause. Here, class, is your dowager's hump. Okay, the decrease in height related to the fractures here on the upper part of your spine. Now, let's talk about the medical management for osteoporosis. Nutrition. So for the nutrition therapy, the diet should be rich in protein. The protein would form part matrix of your bone. Magnesium, vitamin K, and trace minerals. These are important for bone formation. Then calcium is needed, obviously, and then you would have your vitamin D. Okay, so vitamin D to aid in the absorption of your calcium. Alcohol is a no-no, so as your caffeine. And then if your patient had fracture already, protein, calcium, vitamin D, iron are all combined, important to promote bone healing. Then you have your exercise. So exercise could actually help in pain management, cardiovascular function, and of course the sense of well-being. Other than that, your exercise would also help to increase the bone mass. Walking for 30 minutes for 3 to 5 times a week is considered to be the most effective exercise for osteoporosis prevention. Lifestyle changes. Of course, avoid tobacco, and then fall prevention. Okay, so fall prevention and then decreasing the risk for fractures. Now, for the drug therapy, there are different drugs that can be used. So you have calcium and vitamin D supplements. You'll have your estrogen or hormone therapy for those who had menopause. Then you have your biphosphonate, okay, which is the standard of care for management with osteoporosis. Then you have your SERMs, selective estrogen receptor modulators, and then your calcitonin. Combination of these drugs may be used to treat and prevent osteoporosis. Now, calcium. So for men, 50 to 70, it's recommended to be 1,000 milligrams. For women, 51 and above, and men 71 and older, 1.2 grams or 1,200 milligrams. When your patient is taking calcium, increase of water intake is also advised, okay, unless your patient would have chronic kidney problems. Now, vitamin D. If you're aged up to 70, 600 international units of vitamin D is recommended. 71 up, 800 international units is recommended. Daily sunlight exposure would also help. But take note, your vitamin D is not coming from your sunlight. Your sunlight would only activate your vitamin D in your skin. And then 20 to 30 minutes of aerobic exercises. But take note, these aerobic exercises should not be rigorous in such a way that your patient will be at risk for fracture. Okay, it should just be simple exercises as long as it's weight bearing if you want to prevent osteoporosis. But if your patient would have severe osteoporosis, the exercise should be programmed in such a way that it will prevent fracture. By the way, take note that the food sources rich in calcium would include your skim milk, your cheese, your dairy products, your steamed broccoli, your canned salmon with bones. It's the bones there which would contain your calcium. Next, you have your calcium and vitamin C supplements. Your calcium is also given with vitamin C, and the recommendation is to divide the doses. Okay, abdominal distension and constipation is one of the side effects. Now, you have your biphosphonates. Class, your biphosphonates will be able to inhibit osteoclast. Again, biphosphonates inhibit osteoclast. So it is taken with calcium and vitamin D also. Because it inhibits osteoclast, you would need calcium because osteoblastic activity may be proliferating by then. Now, GI symptoms, dyspepsia, nausea, flatulence, diarrhea, and constipation may occur. Okay? By the way, in calcium, constipation is also common. That's why still increase oral fluid intake. So it prevents constipation. It also prevents your stone formation. That's for calcium. Going back to your biphosphonates would also have the risk of esophageal ulcers, gastric ulcers, and even the osteonecrosis of the jaw. Look at it, osteonecrosis of the jaw. So meaning, class, necrosis. There will be death of the tissues of the bones in the jaw if the medication will be staying there. For that reason, your patients who are taking biphosphonates would be advised to remain upright, okay, after taking the drug. Other examples of your biphosphonates are shown on the slide. One is your alendronate. So class, your alendronate is given per orem daily. There is also a dose that is available weekly. Weekly if it is used for prevention of osteoporosis, which means that it will be used among patients who are osteopenic. Your alendronate is best to be given with an empty stomach with 250 ml of water. So the 250 ml of water here, class, would ensure that the medication will not be staying on the jaw, it will not be staying on the esophagus because it might result to necrosis. Added to that, the patient should remain upright for 30 minutes. Okay, it is not to be given with your proton pump inhibitors, so your prazole drugs, omeprazole, pantoprazole, because it would diminish the effect. Another example would be your risidronate. We also have your ibandronate. Your ibandronate, class, is given per orem monthly. It's given IV every 3 months. Okay, then you have your zoledronic acid. It's given IV yearly or once every 2 years if the purpose again is prevention. Now, class, for your zoledronic acid, it is commonly known to cause your AKI, acute kidney injury. For that reason, your patient needs to have a creatinine clearance of less than 35 ml for us to ensure that your patient will not be at risk for acute kidney injury. Other than that, your zoledronic acid is not supposed to be given among your patients who are at risk for chronic kidney disease, okay, or your patients with chronic kidney disease, because this medication is known to be damaging to our kidney, nephrotoxic. Okay, then you have your estrogen agonist or antagonist, or what we refer to as your SERMs, okay, your selective estrogen receptor modulators. An example of which is your raloxifene. Your raloxifene will be able to promote the estrogenic effect to the bone. It's given per orem. And just like your estrogen, among the side effects of your estrogen receptor modulators is your flashes, like cramps, and then the risk for VTE or venous thromboembolism. So the risk for venous thromboembolism. Okay, so take note, class, estrogen, just like your pills, no, which would contain estrogen, these are contraindicated among your patients with venous thromboembolism. Then you have your RANKL, RANKL inhibitor, an example of which is your denosumab. So among the new medications, a monoclonal antibody which is able to increase the bone mineral density. It's given subcutaneously. It has the risk of skin rashes and osteonecrosis. We have mentioned about the surgery earlier. So you have your vertebroplasty and then you have your cephaloplasty. Recall that I've mentioned that this would use your PMMA. So going back to these surgeries, when I say vertebroplasty, it is an injection of bone cement into the vertebral body itself. Okay, so here you can see that there will be an injection of bone cement. The purpose of that is to reduce a fracture. When I say reduce, to repair a fracture or fill the space created by your osteoporosis. Then you have your cephaloplasty. In your cephaloplasty, that would include the use of balloon in the vertebral body. So balloon is placed in the vertebral body to contain the bone cement. The purpose of which is to gently elevate, or the bone fragment in an attempt to return them to their correct position. So, you know why? What happens is that if these bone fragments will continue, or if this bone would continue to break, okay, there will be compression fractures. And the compression fracture will have the risk of paralyzing your patient related to the compression to your spinal cord. Now, prevention. Osteoporosis is a highly preventable disease also. Okay, so there needs to be preventive measures. Take note, okay, this reference would remind us again that the peak adult mass would be around ages to 18 to 25. So there's some variations on reference. But if you would look at it, it's at around 25. Primary osteoporosis. So after menopause, usually by the age of 51, the low vitamin D levels again, and among older adults, the less calcium absorption as they are readily excreting your calcium. Whereas for secondary osteoporosis, that would be related to immobilization. You have your medications or diseases, and then the use of your corticosteroids. Now, example, greater than 5 milligrams of prednisone daily for about 3 months, and then the excessive alcohol intake. Now, what will be our interventions for these patients? Come to look at this. Okay, secondary osteoporosis may be caused by the following diseases. So you have your celiac disease, you have your hypogonadism, you have your malabsorption syndrome such as your Crohn's disease, and then your alcoholism. Okay, class, you also have the following medications that we have mentioned. No? We mentioned this earlier. Okay, along with your diuretics, this medication could also cause your osteoporosis. Okay, so if you would look at this, surgery also, such as your oophorectomy. Oophorectomy would be the removal of your ovary. Okay, so class, the same as your TABSU, which will include the removal of your ovary. This surgery, class, would have the tendency to decrease the estrogen in our bloodstream. Okay, so oophorectomy. Remember, ovary produces your estrogen. Then you have your bariatric surgery. So recall in bariatric surgery that there will be a resection of the stomach. And then you can have your Billroth 1 or maybe Billroth 2. So take note that your stomach along with your duodenum is considered to be the primary site of calcium absorption. So a decrease in the surface area of your duodenum would lead to decreased absorption of your calcium. In other words, hypocalcemia, increasing the risk for osteoporosis. So, here are some of the strategies for preventing osteoporosis. You may pause the slide or you may refer back to your textbook for chart 41.5. Okay, so for the strategies for preventing your osteoporosis. Now, what are the possible nursing diagnoses for our patient with osteoporosis? You have the risk for falls, impaired physical mobility related to the decrease in the muscle strength, pain, musculoskeletal impairment. You also have class acute pain or chronic pain related to the effects of acute physical illness such as your fracture or chronic disability. And then the potential for fracture related to weak porous bone. So what are our nursing interventions for each of these nursing diagnoses? So class for the impaired physical mobility. So weight-bearing exercises may be recommended as tolerated by the condition of your patient. So your weight-bearing exercises may be done at least 3 times a week. Use of assistive devices is recommended. Safety and fall prevention is needed by your patient. You need to evaluate and closely monitor for the medications of your patient. Other than that, you have your altered nutrition less than body requirements. So there could be a decrease in the intake of your calcium. So they need to have food high in calcium. Broccoli, dairy products, a daily calcium intake of 1,200 milligrams per day. Postmenopausal, calcium of 1,500 milligrams per day. Food or fluid that prevent absorption of calcium. And then absorption of supplemental calcium is recommended. They are supposed to take supplement at a proper time. Then, for the pain, review activity tolerance and suggest modification exercise schedules as indicated. So because it is possible that the pain that they are experiencing is related to the exercise that they are doing, anti-inflammatory agents are recommended, along class with their compliance with their biphosphonate therapy. And then, apply heat. The heat could relieve the pain experience of our patients. That will be all for osteoporosis. The next topic that we will be discussing is osteomalacia. Thank you for your attention.